Hello again. Here we are for the sixth conference of the day. This time we go back to the Middle East, to Israel, where our friend and great dentist Dr. Mirella Ferraru lives and practices daily. Dr. Mirella Ferraru is half Romanian and half Israeli. She graduated in 2005 from the dental faculty of the Timișoara University, Romania, and in 2009 she joined the Bichasho Clinic team in Tel Aviv. Mirella gained for the last 8 years in-depth knowledge and experience in all fields of perioprosthetic aesthetic dentistry, where she has been focusing in restorative and perioplastic surgery treatments. By her photographic documentation, Dr. Ferraru has been getting notoriety by her publishing and lecturing internationally on restorative adhesive treatments, interdisciplinary state-of-the-art perioprosthetic concepts and treatments, and on high-demand treatment dedicated dental visualization. I'm very happy to have her with us, presenting a combined way of looking into oral rehabilitation with a presentation entitled Restoring Smiles, the Surgical Restorative Workflow for Predictable High-End Results. I am sure you'll love it.
So, hello everybody and welcome to the second edition of the International Aesthetic Masters. First of all, Joao, congratulations for the wonderful idea that you had already in 2015 with the first edition. And thank you for the effort and the time that you invested in raising such an amazing program again. For me, it's a real pleasure and honor actually to be part of such an amazing group. So, what I would like to share with you in the coming hour will be some aspects that are related to the surgical and the restorative workflow and the way that we try to implement it in our daily practice. And I would like to concentrate and emphasize in details, especially those factors that allow us to achieve, of course, the highest aesthetic results that we would like to have for our patients, and more important, on how to achieve that in the most predictable way. So the lecture will be divided into two parts. We will discuss at the beginning a little bit about the relationship between the cervical contours of our restorations and their impact on the soft tissues. And in the second part, we will discuss a little bit more about the implant-supported restoration, on how and why do we contour with a specific design, and their relationship with the quantity and quality of the surrounding tissues. So basically the lecture will have one clinical concept that will be coming back to it, which is the cervical design. And each part is going to have one clinical case that will going to emphasize in detail our complete workflow. Now, a little bit about my background. I was born and raised in Romania, where also I graduated my university studies, actually in Timișoara. And around 10 years ago, I moved to Israel. The last 8 years, I had the pleasure and privilege to be part of this wonderful team in Tel Aviv, together with Professor Nitzan Bichacho and my colleague Dr. Galit Talmor. So let's start with the first part that is related to the natural dentition. So before that, even starting a specific treatment plan, we have certain sequence that we have to go through. So first of all, the data collection, which is very important. We are trying to gather as much as information as possible regarding the history, the background of our patient, the clinical and relevant radiographs, clinical images and videos. Then already at this part, we will try to understand the expectations of our patient related to the final result, and the entire amount of information that was gathered will be transmitted to our dental technician to the laboratory. Preliminary aesthetic plan project will be elaborated, and this aesthetic plan is going to be tested intraorally with the help of a mock-up. And there are different ways to do that. Today I will not go into details regarding this aspect. But this mock-up is very important because not only it will relate to the final aesthetic result that we would like to achieve for our patient, it will already from the beginning emphasize some functional aspects that we might need to relate to in detail, and it will give us an overall image also of the integration of the entire complex with the surrounding tissues. Jaime Gill used to say, when you don't know where you're going, you can't get lost. And we can understand that there are some advantages from such a way of thinking. So maybe that indeed in the past dentistry was mainly referred to as a repair business because the main focus was in treating a disease, in restoring function, so treating structural problems, and only at the end of these phases would aesthetics come into the equation. And this actually had as a consequence, of course, a compromise result from an aesthetic point of view. Now, in the last 15 to 20 years, things started to change because our patients start to have pretty high expectation when it comes to the final result. So actually what we do today, we start with an aesthetic preliminary plan. And this aesthetic preliminary plan will allow us to identify some structural problems that we'll need to address. So this will become in a second stage. And overall, we are going to look also at the biological integration of the entire complex when it comes to natural dentition or implant-supported restoration, our ceramics, and of course the periodontal structures. So then further on, our treatment sequence will be based on a first phase, which is represented by the control one, in which all the non-surgical periodontal treatments will be performed, caries will be treated, and odontic treatments will be evaluated, and if needed, retreatments will be addressed. At the end of this phase, we have a reevaluation. And only later on, we proceed with the corrective phase, which is the second part of our treatment, where provisional restoration will be inserted. Different specialities will be involved, like orthodontics if needed, bone and soft tissue corrections will be made, and implants will be installed at this stage. And also the second phase will have as a finalization also a reevaluation part. Then we can move to the rehabilitation, where we already achieve a stabilization of the entire complex. We perform some fine refinement if needed, and then we can continue with our prosthetic workflow towards the definitive restorations, and of course end up with the maintenance phase. Now, our goal at the end of the day is actually to achieve this type of harmonious integration between what is related to our ceramic restoration, the cervical contours, and the surrounding soft tissues. And this is regardless if we are talking about two supported restorations or we are having an implant supported restoration, as we are going to see actually in the second part of this presentation. And definitely we want to and we aim for longevity of whatever we are performing clinically intraorally. And for that, we need to follow certain steps, and each and one of them in a meticulous way. So, for example, we will guide our preparations whenever possible in order to be more conservative and less invasive in the amount of tooth structure that we remove. So for example, guided birds, like we see in this clip, the preparation that are performed through our mock-ups. So all this gives us the control actually towards the amount of tooth structure that we will remove. Then later on we will have to take an impression of the prepared teeth, and this is regardless if we are going through a digital workflow, so intraoral scanners will be used, or a traditional elastomeric impression. We still need to know how to use properly traction cords, how to deflect properly the tissue without causing any irreversible damage to the periodontal structures. And then later on, towards the finalization of our case, we will have to use correct and follow rigorously the correct adhesion protocols, proper isolation of the dental substrate, proper conditioning of our ceramic substrate, as well as our dental substrates, which can be represented by enamel, dentin, or combination of the two, and sometimes even composite restorations. Now, obviously, when we have such a starting point, and clinically we take a look at this type of image, we understand that there are certain parameters that we will have to relate in details. So first of all, in terms of aesthetics, obviously we foresee that we can get actual improvement for our patient, but actually what strikes the eye is the lack of harmony in this transitional zone. And the transitional zone, I mean by the space that is defined, the space that is confined between the soft tissue margins and the cervical part of our ceramic restoration. So we can already understand that we might have some structural issues that we will have to address at the time that we remove this ceramic restoration. And even more important, from a biological point of view, we will have to create the proper conditions for those periodontal structures to regain their health. And this discrepancy and lack of harmony obviously becomes more predominant and more striking when we take a look at our patient's smile. So in terms of our sequence of planning, the moment that we remove those ceramic restorations, we see all the composite buildups with infiltrations, so we cannot really rely on the quality also of the endodontic treatments that have been performed. So we decided to redo the endodontic treatments, to redesign the preparation, to provide for the patient with long-term provisionals, and that will allow us in time to address and understand actually the prognosis of each abutment, and then perform a reevaluation. Now, when we remove the ceramic restorations, besides the infiltrated composite buildups, what we see very clearly is a very wide preparation design that actually cut completely the space, eliminated the space interproximally for the soft tissues. So at the first stage, for sure, our aim will be to transform this preparation design that is pretty horizontal into a much vertical one, like a very light chamfer type of design, that immediately we can see clinically that allowed us to gain space interproximally and also to gain more ferrule effect, to gain more tooth structure in the cervical part. So only once our preliminary design, which is represented by the provisional restorations, as we can see here, have been accepted not only from an aesthetic point of view, but also from a biological point of view, when we look at the nice integration of the nice response of the soft tissues towards the new design, so only then we are going to move towards the definitive restorations, and in this case will be actually a copy of the provisional design that the initial design of our provisional restoration that were created. And then, of course, we can see this is already 1 year after installation. These were zirconia-based crowns. We can see a very nice response of the soft tissue, a very nice integration, and a very nice relationship between the different structures, which are represented by the tooth preparation, tooth structure, ceramic restorations, and periodontal support. Now, of course, that whenever a more involvement from a periodontal point of view we encountered at the starting point, that gives us already the impression and the idea that this will be a pretty more challenging case in terms of regaining health of the periodontal structure that were lost, and regaining balance between, as we can see here, the gingival margins between the right and the left hand side. So in order to be able from such a starting point to bring our patient and deliver to our patient such a final result, obviously the entire treatment um, takes several steps, and which one of them are critical for the final result. So as we already understood, we always start with a preliminary aesthetic analysis that will allow us to choose and to analyze the final shape, proportions, and position of the future ceramic restorations. Then the patient will go through initial therapy, and during this time we are also going to control the capability and the willingness of the patient to maintain a proper oral hygiene. Then later on, after the first phase of the control, we are going to provisionize and install the first set of provisionals. And also in this part, we are going to perform the additional periodontal surgical interventions like crown lengthening that was performed in the area of tooth number 12. Following that, we have a stabilization period of at least 6 months. And then at the end of this period, we are going to reevaluate the clinical situation, provide the second set of provisionals that will actually involve at this stage also the teeth that previously underwent periodontal surgical therapy. And that will complete actually our aesthetic analysis. So only at this point, when we see that everything is stable and in balance, we are going to go towards the finalization. We are going to complete the prosthetic workflow and deliver the ceramic restorations for our patient. And then, of course, this is a few months after the bonding, after the cementation, and we can see this beautiful harmony and integration between the different structures, especially at the transitional zone, which is the most critical one, the interface between the soft tissue margins and the ceramic crown. Now, when we take a look at this image, we can see clearly very beautiful smiles, because there is a harmony. There is a harmony and balance between the dental part and the frame, which are the lips. Now, if you take a more close-up look intraorally, what is even more pleasant to the eye is actually the healthy image that we see, especially in the transitional zone. So that area that relates to the soft tissue margin and the cervical contour of our restoration. And actually this is the thing that I'm going to concentrate now in the coming minutes. So let's talk a little bit about the cervical contours, and we see a lot and we hear a lot about emergence profile, cervical design, and so on. So let's try to understand each term, what does it refer to. So when we talk about an emergence angle referred to our ceramic restorations, it is actually the angle defined by two lines. The first one will be actually a continuation of the root structure coming out from the soft tissue margins, and the second one would be actually the line that passes through the cervical part of our restoration. So if this is the emergence angle, we have related to in relationship to the emergence angle, we have the cervical profile of our restoration. Now what is interesting is that actually at a certain emergence angle, which by its term it represents actually a point, we can have different cervical profiles, as we can see in this small drawing very nicely, that the cervical profile can be more contoured or more flat. Now in 1994, Professor Bicciaccio already emphasized and described some of the relationship of the dentogingival complex when it comes to the design of our ceramic restoration. And what he describes is actually the periprosthetic envelope zones. And it seems like we have actually two areas. We have the interproximal part, which were described as the pressure absorbing zones, meaning that in this area the soft tissues have the capability to adapt to any kind of changes in the contours of the ceramic restoration. And then we have a pressure relief zone, which is described by the mid-cervical part, and which also, just by its name, we would in general prefer to be less contour and stay with a more flat design. Now this becomes even more prominent when we are talking about space dentition, because what we are doing when we are closing spaces, actually, we are changing the profile of the tissues interproximally from something that is flat to a new design that is actually more scalloped. And these are actually the prepared teeth, minimally invasive preparation. And if we take a look more interproximally, we see very clearly the position and the relationship between the preparation margin and the soft tissue. And why is this very important? Because when we close spaces, for sure we wouldn't want to end up with black triangles in the final result. Meaning that the dental technician needs to receive from us not only a very precise and clean preparation margin, but it also has to be properly placed in relationship to the soft tissue, especially in the interproximal areas. What does it mean? It means that he needs to have a slightly intracircular position and more towards the palate in these cases, that will allow him to have a correct emergence angle of the ceramic restoration from the preparation margin, that secondly will allow him to have a correct cervical profile of the ceramic restoration in order to be able to close the space and give support for the soft tissue interproximally, and of course obtain such a nice aesthetic result with these ceramic veneers. Now the question that can be raised can be, to which extent can the soft tissue actually adapt? Or better to say, what is the key element or the factor that will dictate the capability or the less capability of the soft tissue to react towards the changes that we perform on our ceramic restorations? So the biologic response is actually depending on the thickness of the connective tissue that we have between the two epithelial layers. And by two epithelial layers, I mean the outside oral epithelium layer and the intracircular epithelium layer. So actually the amount of connective tissue present between these two will be the key element. Now, these slides are courtesy of Professor Pontoriero, and they will emphasize in a very nicely, from also a histologic point of view, what happens from a biological aspect whenever we insert a crown that has an improper cervical profile. So, if this is the amount of connective tissue that we have, as I described previously, we can see that it has a certain width and a certain height. Now, the moment that we insert a crown that has an improper cervical profile, by this meaning that it is highly over-contoured, what we are going to see intraorally and clinically, it will be a vascular response, because this over-contour will cause a compression of the tissue in that area, and this initial vascular response is actually translated by ischemia. In other words, no blood supply. Now, at this point, the soft tissues have two options. And this depends actually on the amount and the thickness of the connective tissue present. Meaning that if we have a thick connective tissue, like in thick biotypes, at the time of insertion of this type of crowns, although there will be ischemia present, in time the soft tissues will be able to gain their vascularizations from the surrounding, meaning there will not be an irreversible change in the position and the contours of the soft tissues. And of course, the opposite happens whenever we are dealing with very thin and very small amount of connective tissue, because they will not be able to adapt to the new clinical situation. That means that that particular part of the soft tissue margin will go through thrombosis, through aseptic necrosis, and actually they will move into a more apical position where they can gain proper vascularization. Now this is what happens when from a histological point of view. Now let's see actually clinically what is the soft tissue effect. So we know by now that when we insert the crown, we are going to see the blanching of the soft tissue. That means a vascular response, which means ischemia, no blood supply. Now, in the case that the soft tissues cannot adapt to this type of over-contouring, as we can see here, the immediate response will be actually marginal recession. It is actually the gap, as we can see here, that we are going to see between the soft tissue margins and the cervical part of our restorations. Now, we know that there is a correlation, and we saw by now a little bit about the implications when it comes to the shape, the cervical profile, a certain given cervical profile, and the preparation type and position. So in order to emphasize a little bit more the previous things that we just described and how the soft tissues respond to over and under contouring of our ceramic restorations, I would like to share with you this case. This was actually a lady that came to the office and she refused to go through any kind of surgical intervention. So her request was to be able to restore her smile just by prosthetic means. So we already at the beginning tried to emphasize what will be from an aesthetic point the major factor that we will have to analyze. And this is, as we can see very clearly, the difference in the positions of the soft tissue margins between the left and the right hand side, and more important also the difference in the contours of these soft tissues. Then we start with our initial aesthetic evaluation and aesthetic project, and this is actually the shape and the length that we decided we would like to have as a final result. Now, according to the shape of the future restorations, we try to understand which areas we would like to over contour in order to change the profile of the soft tissues to be more symmetrical and actually identical with the area of tooth number 11, and which areas we will have to be slightly under contour in order to compensate for this discrepancy and also to let tissue maybe slightly migrate in a coronal position. So once we have the changes that we would like to have in the positions of the soft tissues, we have established the shape of the future restoration. This will actually dictate the position of the future preparation margins, because we can achieve that only if we have the support, the preparation margins at the correct position, so the technician can, at the end of the day, produce this type of restorations. We get from our dental laboratory a wax up. In this case, it involved also the upper and the lower anterior teeth. We tried it intraorally. This is a very important part, because we have to see before we even start if the aesthetic result that we are going to obtain is a satisfactory one. If it satisfies the aesthetic, let's say, expectations that our patient had. And this was indeed what happened. She was very happy with the preliminary view. So we move forward towards the preparation through our mock-up, of course, that will allow us to remove only the necessary amount of tooth structure, and of course a very light chamfer preparation design that went interproximally in certain areas. But what is more important is actually the position of these preparations with the soft tissue, and we can see clearly we try to stay away and not to accentuate this discrepancy between the soft tissue margins. When we look from an occlusal view, we see that some areas we had to open the interproximal contacts, because as we discussed in the space dentition, we need to give the technician the proper conditions to have a correct cervical profile, especially when we want to change the positions and the contours of the soft tissues with the design of our ceramic restorations. And this is actually 1 year after bonding. These were lithium disilicate ceramic veneers, and we see not an ideal result. This is not perfect, but it's a harmonious, and there is a harmony and a balance between the different interfaces. And the patient was very pleased with the final result, and we were actually more pleased to see, after 4 years in function, a very good stability of the entire complex. So now let's go briefly also through our final case of this first part, that will discuss all the steps from the beginning till the finalization of the case. So we had a pretty complex case that dealt with deficient anterior restoration. So we can see a lot of dental treatments that have been performed in the past, old composite restorations, all with infiltrations, recurrent decays, and more important, we already emphasized from the beginning this discrepancy between the soft tissue levels of the two centrals. So as a starting point, we already know by now that we try to underline the main issues that we might encounter during our treatment plan. And this is important because once we will be able to control these factors, it will allow us to be successful in the final result. So first of all, we will most probably have a combination of different restorations, ceramic crowns and veneers. We will have to control the color of the substrate, because we saw we have a pretty big composite restorations that were that the patient presented with. And then we will have to concentrate on the design of the cervical profile between the two centrals. And then, according to our issues or our main problems, we will have also our goals, which means what we would like to achieve at the final of the finalization of our case. And one of the things that we relate always at the beginning, right from the beginning, is actually the expectations of our patient. In this case, he wouldn't want to change anything in the overall appearance of his smile, meaning that he would like to keep the shape of his natural dentition. Then we will have to find a way to rebalance the substrate in terms of color, and this is important especially when we would like to stay very minimally invasive in our preparation and the amount of tooth structure that we are going to remove. So color of the substrate may impose a problem when we are talking about very thin ceramic restorations. So before even starting, actually, our patient goes through serious steps of the sessions of our hygienist, because, as I mentioned at the beginning, the compliance of the patient is crucial towards the treatment. So we want to see that he is actually willing and able to perform and maintain a very good oral hygiene. Then in the second step, we are going to replace all the deficient composite restorations. So we are going to try to rebalance the substrate before going through further on towards the preparation phase. So in order to choose more easily and correctly the composite masses, we use a black and white image to address the value, and a polarized image in order to choose, as I mentioned, correctly and in a more easier way the composite masses. Besides equalizing the substrates in terms of color, at this time we will get also a lot of information regarding the amount of healthy tooth structure that we have remain, because this will also give us a more in-depth information regarding the type of restoration and preparation accordingly we will have. So the decision was to go for a veneer type of preparation for the two laterals and the tooth number 21. Tooth 11 was performed, a root canal treatment was performed. And then, of course, we will have to concentrate and dedicate a lot of attention when it comes to the cervical profile and its influence regarding the soft tissue margins. So these were the different type of preparation designs that we had at the end. So we can see here a minimal preparation type for the two laterals without going interproximally between the contact points, a more close to a 3/4 veneer type of design, and a full crown for tooth number 11. And now at this stage is even more obvious and prominent this discrepancy between the soft tissue margins of the two centrals. So exactly this problem will be related by the technician already in the wax-up stage. So the design and the profile will be established at this part, and we see clearly already from the wax-up that we have a completely different contour of tooth number 11 compared to the veneer that we are going to have on the tooth number 21. So besides choosing the correct shape and color of the future restorations, it's very important the precision and the fit of this restoration. As we can see here, excellent marginal adaptation on the die, because this will have, of course, from a biologic point of view, an impact on the health of the surrounding tissues. And we can see also very clearly that there is a specific design in the cervical part of this restoration. And why is this important? Now, if we go back intraorally and we take a look at the two centrals from a profile view, we can understand the importance of the correct cervical design or a cervical profile of the future ceramic restoration. Because we can see that we have a different space in the cervical area that will have to be replaced by the ceramic. And it's a completely different amount between the two centrals. Then we shouldn't forget we have different positions of the soft tissues that we would not want to increase this discrepancy. So the cervical profile will start more flat, as we can see here, from the cervical margin on the area of the tooth number 11. Then it will start on the area of the tooth number 21. And when we insert this crown intraorally, what we can see and we want to see is actually the lack of blanching. We don't want to see any pressure or any compression on the soft tissues. So we see very clearly the way that the crown starts in pretty flat design and then keeps on with the height of contour of the future ceramic restoration. Now, of course, at the end, when we're getting close to the finalization and the definitive restoration will be bonded, it's very important, as we can see in this clinical image, to maintain the enamel margins. This will allow us to be more predictable and have a long-lasting results when it comes to the bonding procedure and the different interfaces. So we will have to follow a strict protocol when it comes to the conditioning of a different substrate. We will have to refresh the composite restorations that are present. So we are going to sandblast with aluminum oxide these areas. We will use the total etch technique because we have a mixture of substrate, enamel, and some islands of dentin that have been exposed. And we still prefer to use 4th generation adhesive system. In this case, we used Syntac. So we have a very good integration between all the different structures. We added composite restoration on the mesial part of the canines in order to improve their overall shape. The veneers in the area of tooth number 12, 22, and 21, and the crown and the area of number 11. So we can understand it was a pretty challenging case because we had completely different structures to address, different thickness of the preparations, and more than that, also a different relationship between the soft tissue margins of the two centrals. I think that overall we were able to satisfy, first of all, our patient expectations. When it came to the final result, we still maintain this lack of symmetry and actually a disproportion in the arrangement of the teeth, and a beautiful response, a natural image when it comes to the soft tissue integration. Now, in the second part, I would like to emphasize some factors that relate to the way and how do we design the cervical part of our restoration when we talk about implant supported restoration, and the relationship with the amount and the position of the soft tissues. When we talk about optimal aesthetics around implant supported restorations, we know that we talk about having a sufficient amount of volume buccally and interproximally to the implant. So it's all about creating this volume that in terms of numbers will be around 3 millimeters on the buccal aspect of the implant and around 2 to 3 millimeters interproximally and crestally from the implant head. So for that, indeed, we are going to rely a lot on soft tissue grafting. And question would be, why do we do this type of procedures? Why do we need to increase the soft tissue thickness? And there have been several studies in the literature, and this is the one that Uli Grunder published in 2011. And the conclusion was that there is an average loss of volume when we do not perform any kind of soft tissue augmentation, around 1 millimeter, and more actually we gain soft tissue volume when we do perform a soft tissue augmentation procedure, although he related to immediate implant placement in the aesthetic zone. So our soft tissue options for grafting are related to the palatal mucosa and the tuberosity area. So we have different areas to go to in the palate, and more than that, we have different techniques to take these grafts. So if you just take a look at these are different type of grafts that have taken from different areas of the palate, also with different techniques. So we have a fringe gingival graft that has been de-epithelialized. So it's a dense connective tissue graft. We have a tuberosity graft, and then we have a single incision subepithelial connective tissue graft. Now, if you take a look just at two different slides, two different images on this slide, we can see that they look different. They look like having different composition. They are different in volume, and most probably they will have also a different clinical behavior. This is an interesting study published in 2015 that actually showed that despite that we have a high inter-individual variability when it comes to tissue composition of the soft tissue from the palate, just by the technique itself, we can decide the type of tissue that it's going to be predominant in that type of graft. For example, a de-epithelialized connective tissue, fringe gingival graft, will contain much larger amounts of dense connective tissue and less fatty and glandular tissue than a single incision or a split flap harvested connective tissue, regardless of the area where it was harvested. So talking about volume, we know that we can very easily change the profiles and get that nice overall appearance of root prominence that we would like to have, like we have on our natural dentition, just by soft tissue grafting. So we change the profile of the ridge from something concave to something more convex. Obviously, that more complex cases with bigger deficiencies at the day zero of the starting of the treatment will need a more sequenced and delayed approach. So, for example, when we start with such a deficiency of the ridge, which is related not only to the soft tissues but also to the hard tissues in an horizontal and vertical dimension, we first go towards GBR, towards the bone augmentation procedure, try to create a sufficient amount of hard tissues that will allow us to place the implant in the position that we will have prosthetically a possibility to have a screw retain restoration. So we are going to prosthetically be driven at the time of implant placement. We can see the amount of bone that we were able to reconstruct, hard tissues, after the GBR, and only then we move towards the soft tissue approach when it comes to the first stage of the implant uncovering and then a second additional soft tissue augmentation for the pontic side. So this is the time of the second soft tissue augmentation in the area of the pontic of number 12. We can see how we started after the GBR, and this was after the procedure. So the technique that I decided to go for was a tunnel approach, but from a vestibular incision from the mucosa that will allow me to raise an envelope type of flap, a tunnel, slightly raise the tissue also buccally but also crestally. And the type of tissue that I decided to go for was a tuberosity graft. The reason is that this is a highly dense connective tissue. I am more confident that it's going to stay there over time, that it will be stable, it will not shrink as much as other grafts. And one disadvantage of this type of grafts is that they have to be completely covered by our flaps. We cannot leave them exposed. They need to have protection from the surrounding tissues. Then we close the small incision that we made in the vestibular and reinsert the provisional crown. That was a screw retained provisional crown, and change the profile of the pontic in order not to press and compress that area and leave it to have the best conditions for very good initial healing. So if we take a look at them, let's say the way that we started and where we were able to achieve, this was at the day 0, before the GBR. At the end of the GBR, where already the contours of the ridge have changed into much more desirable looking, but still we were not able from an aesthetic point of view achieve that root emergence that we would like to have only after the second connective tissue graft in the area of the pontic. Now, if you take a look at the ridge from an occlusal view, we see even more clearly the changes that we obtain in terms of volume of tissues that we were able to gain. And this volume of tissue, it's a combination actually of hard and soft tissues. There is something that we need to know also about the behavior of this different type of grafts. For example, the study of a group of Jano Ricci that they show that tuberosity grafts have this tendency of giving some hyperplastic responses in some patients over time. So this is also one consideration when we choose a specific type of graft, to understand what are these limitations and what could imply for the future. Now, the topic of the profile of the restorations on implants related to the soft tissue has been a lot discussed. And there was always this question, where will those modifications be placed? So in order to didactically to make it more clearly, the group of Ernesto Lee published this article in which they actually divided and they described 2 areas on an implant-supported restoration. First will be called the critical zone, that it relates to the 1 millimeter, that it's close to the free gingival margin, so it's 1 millimeter of the ceramic crown close to that area, and everything that is below that up to the implant head, they called it the subcritical zone. Now, this is important, but it's more important to understand what are the implications of these areas clinically. So Any changes that are performed in this critical zone will have an impact, first of all, on the gingival margin level. So obviously, the more over contoured, the more apically the gingival margin will position, and more under contour we are, more coronally they will be positioned. They will determine the so-called zenith uh, position of the final restoration and will have an influence on the crown shape and length. Now let's say that we would like to have some modifications on the soft tissue margins, but we will not desire to have any change in the overall crown shape. Then we can perform some modification in the subcritical zone, meaning everything that is below that 1 millimeter up to the implant head. But in this part, the tendency is always to go for a concave shape or concave profile, or let's say tulip shape profile, meaning that we will always start narrow at the head of the implant, and then the aspect, the design can be more divergent. Now, the more that it is concave or convex in this area, it's also related to the position of the implant in a bucco-palatal way, and also on the amount and thickness of the tissues that we have buccally to the implant. So if you take a look clinically from an occlusal aspect, we can see that we have the subcritical zone, as I mentioned, from the implant head to the 1 millimeter area of the soft tissue margin, and that 1 millimeter part will be the critical zone. There's always another aspect that we have to relate to, which is the timing that is important when it comes to the design of our restorations. What do I mean by the timing? Meaning that every time we have an immediate procedure that has been performed, it can be an immediate implant placement with an immediate loading, and we perform any kind of soft tissue augmentation procedure, the design of our restoration, which usually is a provisional restoration, will be of soft tissue support. We're going to see very soon what do I mean by that. The difference is whenever we are dealing with tissues that have already matured, and this can be either on the provisional or definitive restoration phase, we have soft tissue manipulation, meaning that we can contour the position and change the design, the position of the soft tissues with our restoration. Now, going to the immediate part, for example, this central incisor was removed. This was a case of immediate placement with immediate loading, and the connective tissue graft was inserted. In that case, the provisional will be much shorter than the area of the adjacent teeth, because the idea is not to compress this area, especially in the first part of the healing. We saw already on teeth-supported restoration, when we compress the tissues, there is a vascular response. Vascular response is being translated by ischemia, by lack of blood supply. So we would like to have exactly the opposite whenever a soft tissue graft has been performed, or whenever a regenerative procedure has been performed. We want to have as much as blood supply as possible coming to that area. And then we wait for the healing, the maturation, and we finalize the case. The situation is different, as I mentioned, when we have soft tissues that are mature. This was a case of immediate placement, but it was a staged approach. There was a socket seal augmentation procedure performed, and only after the uncovering and the time of the placement of the definitive restoration, then we can compress those tissues and determine the final positions with the new design of the ceramic restoration, because we already know that those tissues will adapt because they have sufficient amount of connective tissue that can get the vascularization from the surrounding area and then can adapt to the new design. So this is basically the very important aspect when we talk about the design and the time that we insert this type of restoration, which is related to the quality of the tissues at that time. So after soft tissue augmentation, provisionals, as we saw, whenever we are overbuilding our tissues, we are going to have provisional restoration that is going to be under contour. And this is something that the patients are being informed that from an aesthetic point of view, this will be a problem. But it's something that they have to understand. After the maturation, when we start with the prosthetic workflow, we see the position of the implant abutment, and we see the difference of the levels, of the soft tissue levels between number 11 and 21. On one hand, this is exactly what we would like to have around our implant supported restoration, as much as soft tissue as possible. So as we see, the design of the implant abutment was as a prepared tooth, because we are going to have 3 additional veneers on number 12, number 21 and 22. So if this is the position of the time of insertion of the soft tissue, but this will be actually the position that we would like to have after the bonding of the ceramic restoration. So what do we actually have? We will have 4 veneers that will be bonded on these 4 anterior structures, 3 related on natural abutments, 1 will be an implant abutment. It's much easier for the dental technician to control the final aesthetic result when he has the same thickness of the future restoration. The contour of the veneer on the implant abutment will be the one that will determine the shape and the gingival margin, because it will have that critical zone, as we saw, influencing the positions of the soft tissue. So if you take a look at the final crown on tooth number 11, we have one piece screw retain restoration, and this is the area of the critical zone that we previously saw. And this is before the insertion, and we can see very nicely the adaptation of the soft tissue, the way that we can compress, and the way that they adapt to the new design. So we see a very nice integration also with the hard tissues on the radiologic aspect, with clinical view from the front with the surrounding tissues, and also from the profile, which emphasizes very clearly the health and the very good response that we get from the tissues surrounding those restorations. Now, towards the end of my presentation, we will go through a case that will be a combination of teeth and implant supported restorations, and we are going to see the complete workflow. So first of all, we are having, as we see, a questionable number 11. In the aesthetic zone, we have some uneven gingival line, margins, old ceramic restoration, and periodontally compromised teeth. 2015, this is how the patient presented. The tooth number 11 was already structurally compromised and not able to be restored anymore. We perform a CBCT just to understand that if we are dealing with an implant if we are dealing with an implant situation, what will be the amount of bone surrounding this root that we have as available for us. We try to understand the main issues. Again, we are having a hopeless tooth in the smile zone. We already know that this will be a pretty critical and stressful type of treatment because of the high aesthetic expectations of the patient. We are going to have to deal with the deficient soft and hard tissues. That will lead us to decide if we go for an immediate, delayed or late approach, and in terms of aesthetic, if any changes in form and size will have to be addressed. So part of the treatment plan is always following, first of all, the expectations that the patient has. She wouldn't want to go for a bridge option. We always, at the beginning of the treatment plan, try to give to our patient the most straightforward, simple, and predictable solution, especially when it comes to the aesthetic zone. But this was not the case because we got a pretty negative response from the patient, so she wanted actually to have single teeth, single crowns like she had before. That leads us to the treatment plan that relates to the extraction of number 11 and go for a staged approach due to this deficient type of soft and hard tissue that we had to deal with. So the approach will be a late implant approach, and we try to concentrate on minimally invasive surgical techniques in order to minimize the surgical trauma and also the invasiveness of the surgical procedures. So the time of extraction We aim for a rich preservation procedure. This was the ice cream cone technique published by Dennis Tarnow and his co-workers, where I used highly cross-linked collagen membrane where I had missing buccal plate, and filled up the socket with a mixture of allograft and xenografts, 80 to 20%. As you can see, there was no intention for raising a flap, so everything was left for secondary healing. Just a collagen sponge on top of the membrane that covered the bone substitute, and mattress sutures to stabilize everything in place. The patient received the provisional restoration, and again, timing is important and the design. So the contours of the pontic in this area will be much shorter and will not apply any pressure in the area that the socket was augmented. We waited around 6 to 7 months before we perform a CBCT, and we see we were able to maintain very well the volume of the ridge where the tooth was extracted, but we see that in case of an implant placement, most probably we'll have some threads exposed in the apical part due to the position of the incisive canal. Sometimes unpredictable factors do interfere, and while we were ready to restore the area of number 11, she actually broke in an accident, a C accident, also tooth number 22. And then we need to adapt to the new clinical situation. So we need to reset our goals. We will have a late implant placement on the area of number 11, but we are going to have an immediate implant placement on the area of tooth number 22. So this was at the time of the surgical intervention. I will not go in details at this part of the implant placement because this is something that Professor Bichacho will share with you during his lecture, I think the next day. Just to show you that exactly as we planned, this is what we see clinically. This was the area that we were able to maintain the volume of the ridge, but we still had the threads exposed in the apical part, as we foresee from the CBCT. And we see very nicely the entire structure present intact around the immediate implant case. So we have the buccal plate in place. And this is also a very important factor when we talk about final aesthetic results in implant-supported restoration. Then we slightly augmented the site only where we had those threads exposed in the area of number 11 with a mixture of bone substitutes, the same allograft and xenograft, collagen membrane, highly cross-linked collagen membrane, periosteal sutures to stabilize everything in place, and then we use PRF on top of everything for a better initial healing. We also augmented the gap between the buccal aspect of the implant and the internal part of the buccal plate. We know already that at the time of extraction, this part of the buccal plate will resorb because it is part of it is being represented by the bundle bone, and the bundle bone is a tooth-related structure. So in time, it's going to resorb. So we always augment between the implant and the buccal plate this area to give stability for the entire complex. Then we wait for osseointegration. In this case, we waited around 4 months, and then we went for the uncovering. And at the time of uncovering, we'll try to analyze the type and the amount of deficiency that we are dealing with when we talk about volumes. So, very small incision to remove just the cover screws. A digital impression was taken that because we wanted the patient to receive in 24 hours a provisional restoration. And then we proceed with a tunnel approach to create a slight space where we would like to insert the connective tissue grafts in both sides of the immediate and also the delayed area. Then we go for the palate, and the decision was to go for a free gingival graft that we remove the epithelium, meaning we have a connective tissue graft that is pretty dense and will be stable in time. We measure the areas that we have to augment in terms of the size of the graft that we will have to take. So we see that in the area of the immediate, we needed a much smaller graft in dimensions and a bigger one in the area of the delayed implant, because we would like also to augment the base of the papillas. It's very important. This aspect is very important because we started with the deficiency at the day 0 and the area to number 11, and we had everything maintained in a very good shape and position at the area of the immediate implant. So the profile of the soft tissue has changed immediately at the end of the intervention. We see very nicely the amount of volume that we were able to gain, and we know that these tissues will, with time, will mature and will become even better. So these were the provisional restoration we provided for her, were Katka, milled, composite. And what is important also, we go back to the design of this provisional restoration when we insert them, that is related to the time. So we had a soft tissue graft inserted. We do not want to impair with the initial healing, so the soft tissues will have to give support for the tissues. The provisional restorations will have to give support for the soft tissues but not compress this area, meaning that we tell our technician to stay approximately 1 millimeter away with the margins of the provisional restoration from the soft tissue margins. Then we wait for the healing. This is around 8 weeks, and related to the position of the implant, we see a very nice amount of volume that we were able to gain. And then we move everything to the field of in the area of the dental technician, because we take an impression of the present situation, and it's up to him now to create and to contour and to create a proper cervical profile of this restoration according to the soft tissues. Meaning that he's going to have an original model that it's reflecting the clinical situation, and he's going to have an ideal model with an ideal waxa, which reflects not only the future shape and the size of the teeth, but also the correct positions of the soft tissue margins. So he's going to mark the new gingival lines, as we see in red. He's going to copy this position of the future soft tissue margins with the silicone key, silicone index, and is going to transfer the positions of these gingival lines on the working model, which reflects the clinical aspect. Then he's going, due to the fact that we augmented the tissue, so we have soft tissue in excess, he's going to carve away from the gypsum, from the material, in order to give the correct profile for the ceramic restoration. So he's going to redesign the envelope. This is actually the model-based cervical design, or the cervical contouring concept that was described by Nitan, but when it came related to the implant support restoration. What does it mean? This means that we are going to perform all the changes in order to achieve a correct cervical design of our implant supported restoration on the model. According to that, we are going to insert the ceramic restorations intraorally, and the soft tissues are aimed to adapt to the new design. So all the changes that we are aimed to be made will be made on the model. So we are going to have on the model an ideal gingival profile following the cervical contouring concept that we discussed, both on the area of the natural abutments, also in the area of the implant supported restorations. So we're going to have a hybrid crown, a hybrid abutment, a zirconia abutment with a ceramic veneer on the buccal aspect that will allow us to have a true bonding of a lithium disilicate veneer or three-quarter veneer on this. Then we go through the adhesive bonding protocols, and this is important because we have different substrate. We have different type of ceramic substrate that we will have to address. So we have an IMAX, a lithium disilicate three-quarter veneers, and we have a zirconia core that has ceramic, buccal ceramic for the proper adhesion. As you can see, these are the steps: the conditioning, etching, sealing, the bonding, everything extraorally. This is possible when you have such a perfect adaptation and very good fit of the ceramic restoration on the abutment. Then everything is being polished, trimmed, cleaned, and then reinserted. And this was 1 week in function, and we can see that the tissues start to adapt to the new design. And this is already 2 years, it's a little bit more than 2 years since we inserted the ceramic restoration. Now what is very nice to notice that we have, as we foresee, a very good result and very good stability of the tissues where we have everything in place at the day zero. And it's much difficult to reconstruct or to rebuild something when, especially when we had some periodontal loss of the adjacent teeth. This is this view of the patient while smiling. We can see that there is a slight discrepancy in terms of the amount of papilla that she shows during smile, but still it's a pretty harmonious result with a very good integration with the hard tissue, as we can see on the radiologic aspect. But also when we look at the profile and we analyze the response of the soft tissues around this ceramic restoration. Now briefly, towards the end of my presentation, I would like just to emphasize some of the guidelines that we try to follow in each and every case. And we think that it's very important to establish a proper and efficient communication, regardless if this is related to an interdisciplinary approach, which is the way that we treat majority of our cases today. So between the different specialities with the patient, especially when it concerns the expectation, and of course with the dental technician, that we will have to be able to deliver and meet the final expectation. Analyze each case in depth, plan top down, meaning have the end result in mind already at the beginning of the treatment. Try to control each treatment step. We try to understand, more important, to respect biology and biologic principles. Technique can change, materials can change, but biologic responses and biologic principles stays the same. We'll try to preserve when possible or augment or reconstruct when we have deficient soft and hard tissues, and we will always try to aim for a minimum of 3 millimeters in volume, regardless of if this is mainly hard or soft tissue. But we need to have at least minimum of 3 millimeters in volume when we talk about implant supported restoration. As we saw, we will try to be minimally invasive in our procedure, both prosthetically for the reasons that I mentioned, but also surgically, not only to decrease the surgical trauma, but also the invasiveness of certain procedures. And with this, I would like to thank you very much for being here and listening. I would like to wish you wonderful 2 more days from this wonderful program that Joao prepared for us. Thank you very much and wish you a lovely day.